A simple urine test can flag proteinuria protein leaking into your urine, often an early warning of kidney damage. The good news: alongside medical care and smart habits, 3 vitamins can help calm inflammation, support blood pressure inside the kidneys, and reduce oxidative stress, the same pathways that drive protein loss. Proteinuria in 30 seconds healthy. Glomeruli, your kidney's microscopic filters, keep protein in the blood. When sugar, pressure, or inflammation run high, those filters get leaky and protein spills into urine. Reducing proteinuria helps slow kidney damage. That's our goal today. Baseline: moose dose, control blood pressure and blood sugar. Quit tobacco, sleep, move daily, keep sodium low. And review meds, especially NSAIDs, with your clinician. Vitamin number 1, vitamin D. D preferred. Why? It helps stamps down inflammation in kidney tissue, helping the filter walls swell less and leak less. Modulates RAS, renin-angiotensin system, to ease intrarenal blood pressure stress on filters. Antioxidant support. Helps defend against free radical injury that scars glomeruli. What the evidence suggests, plain English. Trials are mixed on kidney function numbers, but several analyses show lower albumin protein in urine with vitamin D therapy, especially in diabetes when appropriately prescribed and monitored. How much? General RDA 600 IU per day, 15 mcg for adults. 800 IU per day, 20 mcg, if is greater than or equal to 70. Many CKD patients need personalized dosing based on labs to 5-OHD. Calcium, phosphate, PTH. Follow your clinician's plan. Food sources: fatty, fish, salmon, mackerel, cod liver oil, egg yolks, UV-exposed mushrooms, and fortified milk, plant milks, yogurt/cereals. Tip: take supplements with a meal containing fat for better absorption. Choose D-cholecalciferol unless your clinician says otherwise. Safety fats: soluble, don't mega dose. Avoid 4,000 IU per day unless your clinician is monitoring, if you have high calcium or calcium oxalate stones. Discuss D dosing first. Vitamin number 2, vitamin E, alpha-tocopherol. Why? It helps potent antioxidant that protects cell membranes in the filtering units, supports healthy cell maintenance. Autophagy balance, important. For repair, may reduce inflammatory signaling that worsens leakage. What the evidence suggests: early data in diabetic kidney disease are promising, but not definitive. Some studies show trends toward improved urinary albumin with appropriate dosing. Others are neutral. It's reasonable only under medical guidance. How much? Hardy, 15 milligrams per day. Approximately equals 22 IU natural alpha-tocopherol. Some kidney protocols use short courses of 200 to 400 milligrams. Day doctor only. More isn't better. Food sources: sunflower seeds, almonds, peanuts, wheat germ, and vegetable oils. Safflower, corn, soybean. Veggies like pumpkin, asparagus, red bell pepper, spinach, avocado. Mango. Safety: high dose. Long-term vitamin E can increase bleeding risk and, in some studies, risk of certain cancers. Be careful if you take blood thinners, warfarin, DOACs, or have bleeding disorders. Always take with food containing fat for absorption. Vitamin PASH3, vitamin B9, folate, folic acid. Why? It helps antioxidant and anti-inflammatory support for kidney tissue, lowers homocysteine, which is linked to vascular and kidney injury. In advanced CKD dialysis, may support vascular access health and help counter some high phosphorus effects as part of a broader plan. What the evidence suggests: large trials, for example, hypertensive CKD cohorts, show that daily folic acid with standard care reduced CKD progression and proteinuria over time. How much? Shardy, 400 mcg. DFA per day, dietary folate equivalents. That equals approximately 240 mcg folic acid from supplements, or 400 mcg food. FOLATE. Upper limit for folic acid from supplements, fortified foods. 1 mg per day, unless your clinician prescribes more. Some late-stage CKD patients are given up to 5 mg. Day doctor only. Food sources: dark leafy greens, arugula, kale, spinach, broccoli, asparagus, Brussels sprouts, eggs, legumes, kidney beans, peas, walnuts, flaxseed. Fortified breads, cereals, pasta, corn, masa. Rice. Safety: high folic acid can mask B12 deficiency. Get B12 checked if supplementing diet. Stick to clinician-directed doses, especially in advanced CKD or pregnancy. How to put this into action? Kidney safe. Practical ask for labs: UACR, albumin, creatinine ratio, eGFR, BP, A1C, glucose, lipids, plus RSHWOD, calcium, phosphate, PTH. B12 folate as appropriate. Food first. Build meals that supply DE folate. Use supplements to fill gaps your labs show. Dose smart. Avoid more is better. For any vitamin above the RDA, only with clinician guidance. Control the drivers: low sodium, high fiber, minimally processed diet, movement, medication adherence. Avoid routine NSAIDs. Watch for red flags: rising potassium, swelling, worsening, foamy urine, shortness of breath, or fatigue. Call your clinician. Sample one-day plate. Save this breakfast: fortified oatmeal with blueberries plus walnuts. Egg or Greek-style yogurt if allowed. Lunch: kale, cabbage.